Welcome to the Three Voices podcast. I'm Jamie Blue. We are here to talk about our experiences that get labeled psychotic, including voices, mania, paranoia, and unusual beliefs. Some of us have been hospitalized and given diagnosis. Some of us have not. We are free to use any language we want to explain our experiences in extreme states, including salty or triggering language. Some people sometimes describe their experiences as positive, spiritual, or supernatural. We are here to share, listen, and learn. So it's okay if you hear things you agree with or disagree with. It's okay if people like their meds or don't like their meds, like their doctors or don't like their doctors. We respect a diversity of views. I would like to go on record and say that we are not professionals, doctors, or therapists. We are not giving advice. We are simply peers. We are telling stories and experiences from our own perspectives, and we are hoping to share what we can glean from those experiences and from common knowledge that you yourself can find through the internet, books, and other media. We will give links in the description so that you yourself can do your own research. If at any time you believe that you might have something that may need to be diagnosed or treated, we recommend that you seek professional help. After the conversation, we decided that there were a few things I wanted to bring to your attention to help make this a little clearer for you. First off, I would like it to be clear that open dialogue is part of clinical trials in a wide range of areas. It is being practiced in various different forms in parts of Italy, as well as South America, Portugal, Greece, Ireland, Iceland, Poland, Denmark, the Netherlands, Germany, Austria, Japan, China, and a variety of other different places, all at their own individual stages. There are different clinics in the United States that are practicing open dialogue at their own level, and it looks different for each clinic. The foundation is what's important, and the thing that is most intriguing about open dialogue is that it was founded more than 30 years ago in Western Lapland, Finland, by a diverse team in a hospital. And it was founded during a time that schizophrenia was at an all-time high in Finland. And this was an innovative approach that involved the person experiencing the mental health crisis and their family and network individuals, as well as the system of care. Now, they have been able to do research on those that have been diagnosed with schizophrenia, who were in crisis and have gone through open dialogue as a form of treatment, and then had a 2-year checkup. And in Western Lapland, 75% of those who had psychosis and returned for the 2-year checkup had returned to work or to studies. And of those, only 20% were still taking their antipsychotic medications. This is not an alternative to standard psychiatric services in Western Lapland. This is a comprehensive approach to a well-integrated inpatient and outpatient service. Open dialogue sees psychosis as happening between people, not within a person, and putting the attention on helping improve the social relationships surrounding the person in crisis as the key to the recovery. Open dialogue addresses the problems of networking the relationships surrounding the person in crisis, rather than assuming that the problem is inside the person's head. Helping the social network, including changing the attitudes of providers, rather than just focusing on achieving a change in the person in crisis. Open dialogue has achieved dramatic treatment outcomes, avoiding hospitalization, lowering the use of medication, and getting people through crisis. The aim of the treatment meeting is defined by that of the dialogue, in which the patient can find a voice and thus reduce the person's sensation of isolation. This means that the meetings are all individualized. The approach is emphasized in the process of finding the language for psychotic experiences that previously was inaccessible and creating a shared understanding of the crisis within the network. Our guest today has had the opportunity to not only be trained in open dialogue, but has been practicing to the best of her ability some of those skills here in the Northwestern United States. I'll be putting links in the description for a variety of different ways to look into open dialogue. But in the meantime, now to our interview. I'll let you introduce yourself.
My name is Alita Taylor. I'm a family therapist in Tacoma, Washington, and I'm an open dialogue trainer and supervisor and facilitator. Happy to be here.
Thank you. I'm glad to have you here. Can you explain what open dialogue is?
Yeah, open dialogue is the mental health care delivery system in Western Lapland, and it's been the way it is still today since the 1980s, and it has gotten a lot of attention over the last few decades because of its extreme reduction in cases of schizophrenia. It went from one of the highest in the Western world to the lowest over the course of a short time. And researchers began to look at what they were doing during that period of time that reduced hospitalizations and unemployment and disability and neuroleptic use pretty drastically. And they came up with 7 principles that sort of summarize the way that their mental health service acted consistently and still do. And the name Open Dialogue came out of that research.
So what is the difference between that and what you would see if you were to go into counseling normally?
Normally in the U.S.?
Yeah.
Okay. Well, in the beginning, they wanted to reduce hospitalizations, and so they just started doing things differently. And then later on, the principles were garnered or summarized. So what they found in the way that they were working was that they would respond with immediate help. They would always answer the phone. They had shared responsibility. They would have psychological continuity. So a lot of times they would meet in the person's home, but the team that was assigned to them, and they would always respond with multiple professionals, and that team would always stay the same. They would involve social networks of the person that was in crisis, and they wouldn't go off of any kind of prescribed way of introducing care. It was a need-adapted approach where the patient or the client or the family and the person of concern would determine what they wanted in terms of help. So at the beginning of every network meeting, which was their treatment session, which always included multiple professionals, including the doctor and maybe a nurse and therapist or what have you, and the family and close friends and the person, they would ask, how would you like to use this time? And then they would end the session with, when would you like us to come back, or how would you like to go on from here? Other principles were they wouldn't always meet in the hospital. They would meet in people's homes. And polyphony, which is having multiple perspectives or multiple voices. That has to do with shared decision-making and allowing all the voices to be present, including perhaps the voices of somebody who's having an altered or extreme experience. They were slow to diagnose and slow to introduce neuroleptics if needed, and were really flexible with what they offered for help. In other words, if they needed to maybe have a nurse spend the night in the home for suicide precautions or something like that, they would just kind of think about different ways that they could help to avoid hospitalization if they could.
That sounds amazing. Much more preferred to anything I've ever experienced. How did you hear about this?
I worked for many years in an emergency room in a hospital doing psychiatric assessments and kind of vetting discharge plans for people, doing inpatient admissions and finding solutions for people and referring them to appropriate sources. And over time, I began to see a lot of recidivism, a lot of inability to really give families and those in crisis what they needed, because the system was pretty fragmented in terms of levels of care and being able to help right away. And I really enjoy being with people, sitting with people, and I did a lot of self-care, including going to retreats and seminars and conferences on things I was interested in. And so one of the things that I went to was at Esalen Institute in Big Sur, California, which was for mental health professionals. It was called the R.D. Lang Symposium. It was a number of presentations having to do with other ways of mental health care. And I met Nick Putman from the United Kingdom, who was invited there to talk, and Will Hall, also from California, and had taken a year of open dialogue training. Both of them presented open dialogue as an option, and it was kind of like a light went on, and I thought, this really makes a lot of sense. Why are we not doing this, especially when there is so much research that they presented available showing its effectiveness? So I applied to be part of the first international Training the Trainers group in Helsinki, Finland, and I went there 8 times over the last 2 years. I finished in September under Jaakko Seikkula, who was the main psychologist researching a lot of these ideas. And it's the best training I've ever had, and now I can't unknow it. And I am running trainings here with Nick in the U.S., and I want to train as many people as possible in working this way.
That sounds amazing. As I understand it, you have a training coming up soon, is that right?
Yes, in 2019. We're going to start in April, actually.
That sounds great. What does a training actually look like? Can you share?
Yeah, so this particular training is called the Foundation Level Course in Open Dialogue. It's a year, and it's 20 days, full days, spread out 4 times over the course of a year. And it's Wednesday through Sunday in Tacoma, Washington. This has been, the curriculum that's within this course has been rolled out in other countries over the last 10 years. It was developed by Volkmar, Anderhold, and Peterholm in Germany. And Nick has trained with other international trainers in Australia, in Denmark, and the UK, and other places. So it's kind of a tried and true curriculum, because it teaches you how to do a network meeting. It teaches you how to do reflections. There's small group, family of origin work. There's experiential learning. There's homework where you actually get to practice the work and then bring it back and get supervision. And of course, all the lectures and materials about the research in open dialogue is also part of the study.
That would make sense. I would imagine that you go for the first piece of training and then you would take skills home with you to use and then come back with that experience for the second piece and probably have a whole bunch of questions.
Yeah, it's a kind of a new way of working. It's not, I don't think, brand new to human beings, if you can kind of remember just what it's like to sit with uncertainty and sit with people who don't know what to do and are having a lot of unknown and scary places. And what's nice is that working in teams, you share that together, and with multiple perspectives and with a dialogical point of view, people have really infinite numbers of ways that they can see things. And it's not really about resolving anything or prescribing anything. It's really more about allowing a dialogue and allowing enough time and space for people to relate with the ones that are in their lives, their own loved ones, their own social network. And so it kind of puts professionals a little bit more, I won't say on the back seat, but sort of in more of an observer role, where allowing is more important than intervening. But it's also nice to have the wealth of experience of many family therapists and psychiatrists, and they've gone to school and have sat with lots of people, and they are there as a resource. But what I see in open dialogue is what's really refreshing is that there's kind of an equal weight of put on how people want to decide to move forward, and the meaning of what's happening can emerge and take place, and we don't have to totally understand it and put a name to it.
That makes sense to me. So when you came back from your training and you started applying this, what was that like?
Well, I had homework in between my sessions, and I had to get creative because I was in individual private practice at the time. There was a home here in Tacoma that invited me to do a network meeting for one of their residents, and that was one of my videos that I brought back for supervision. And I invited to that meeting friends of the resident, parents, the house managers, the roommate, nutritionist that he trusted, psychiatrist that his roommate used to see that he invited. And I held a network meeting, a few of them, over many weeks. And it was quite amazing, actually. All of them really appreciated it and felt like kind of a timeless space and a way in which that I wish that I could practice all the time. Another thing I did is I met a peer professional who is a Hearing Voices Network facilitator who attended one of those network meetings invited by the person of concern. And we formed a team together in the clinic that I work at, together with a psychiatrist himself and me. And we have been seeing 3 or 4 families that have just come to us and sought out this way of working, and it's been my favorite way of having psychotherapy sessions. Really, it's the best. I feel really fulfilled when I'm able to do that.
That sounds beautiful.
Yeah, I learned so much, and it's a continual process. I wish I could work that way all the time.
Yeah, I think that there are a lot of people who wish the system worked like that all the time too. So
yeah, I've heard that a lot, actually.
Yeah. So you're doing this training. What is your hope for the people that you're going to be training? That you're going to be, I mean, essentially you're planting seeds for open dialogue. So what is your hope? What is your dream? You're the seed that's been planted here. So
Well, there are many seeds, and wherever all the people that come to the training come from are going to get these skills. And so my hope is that those people can get the support that they need in order to practice this way. And what that translates into is that the greater mental health policy makers, and when I say greater, I mean, how reimbursement happens and how county mental health organizations look at their financial structure of covering staffing and covering crisis and covering inpatient units versus peer respite centers versus all the things that have been developed to kind of address a lot of mental health crises that are sort of in separate categories. My hope is that the people that take the training have some kind of access and voice, and that others around them in their communities are interested in figuring out how to apply these principles that really work, that we know from research really work for the last 30 years and are still continuing to work for them in their area of 65,000 people. And I hope that the policies start to take good advantage of the research showing of how much cost savings there is, and not only cost savings in terms of like care delivery, like pharmacy benefits and hospitalizations and disability allowances and unemployment, but like actually the satisfaction of the families and the communities and the strength-based self-esteem that comes from somebody going through what could be called a psychotic experience or any other experiences, which, by the way, in Western Lapland, they use this way of treating people no matter what the crisis is that they're having. So they don't necessarily have to name it psychosis. The only reason that we know that schizophrenia has reversed its course in that area from being really the highest to the lowest now is that that's what they studied was psychosis and first break psychosis. And so my hope is that those seeds that come out of the training can provide for their communities a way to change the way we practice mental health in our country.
That gives me a lot of hope. And yeah, you bring up a good point about the cost, and it is something that I think gets glazed over because it's more than just care. It's care that creates preventative care. And I am a big advocate for preventative care. And I think that's what draws me in because it's building that support network, and everybody in the support network gathers their tools and their skills. And I'm just so impressed by that. And I have such hope that I'm hoping that it gets picked up by more and more clinics. And I actually was wondering, I mean, I know it's to be used in clinical settings, but is it something you think could be used in peer settings as well?
Yes. You mean like respite centers?
Yeah.
Yeah, I think that would be a perfect place to use it because that's where people are going to go. And so part of the flexibility and mobility principle is to make it easy for people to get help.
I love that. I love that.
Mm-hmm.
Do you know, right now, of course, you practice, but do you right now know where this is practiced? Like if people wanted to find somebody who practices open dialogue, how would they go about finding someone?
Well, nobody practices open dialogue anywhere but Western Lapland. So technically, I don't really practice open dialogue. I try to apply the principles as best I can, but I, as an individual, and even I, with my team of 2 other people, cannot apply all of the principles of open dialogue practically because we're not a crisis service. We're practitioners working out of a clinic, and we don't meet in people's homes right now for numerous practical and insurance reasons because of where we work wouldn't cover that. We'd have to start our own organization and make that something that we put into practice and cover. And we also can't immediately help people because we don't even answer the phone at where we work. So there are a number of limitations. So what we're doing and trying to put into practice is that we're providing the network meeting portion of what they do practice in Western Lapland. And I hope that after some period of time, I hope it's not, decades, but I hope after some period of time, the stakeholders and the insurance companies and the healthcare groups who own, multiple levels of care and hire staff in multiple levels of care. And what I mean by that is inpatient, residential, partial, intensive outpatient and outpatient crisis and all of that, realize their cost savings in hiring staff and rolling them out to be a continuous team for people wanting help in their families. So that, there are a lot of ways in which this can easily be done if we were able to kind of reformulate what our goals were and what our mission is for how to take care of our communities.
Yeah, right. I guess it is kind of difficult given the way American insurance and politics work. It'd be difficult to make it run the way it runs there.
Yeah, and it doesn't need to run the way it runs there because we're a different place, but it can apply the principles as best it can and use what we have. And all that takes is communities and behavioral health policymakers to organizationalize it and take what works and is already working. There are a number of early psychosis programs that have trained staff, and they could just probably benefit from some additional dialogical training and learn how to run a network meeting and learn how to do reflecting. There's a lot of things in the training that would be able to continue doing what their goal is, which is to reduce chronicity, whatever you call it, whether you call it CBT for psychosis, whether you call it collaborative, integrated care approach. There are all kinds of programs that would really be able, actually, in many ways, with just adding a few features and with reconstituting the way that they respond to crisis and the way that they manage inpatient care and redefine diagnosis at crisis and see the long-term benefits of this. If they were to apply them as best they can, it's not impossible. It's really just kind of having a little bit of a philosophical and community goal to just listen to one another and to examine, what are we doing here? What really are we trying to do? I think it's important for people in mental health care, all the way to the administrative level to the people on the ground, all of them to ask, what is it we're really doing? And it doesn't need to be hierarchical. People in the business world or in the healthcare policy bean counting world don't need to be afraid of this, because actually this saves money and it saves communities and society and chronicity. And I kind of wonder whether our suicide epidemic has to do with the hopelessness of how we're trying to take care of one another. I can't say that open dialogue has robust research having to do with that. I think it's about equal with people that receive that versus not, but in terms of the suicide rates. But in the U.S., we don't know what implications it would have to reduce those. We have lots of suicide prevention programs, and there's a lot of research going into it. But I think if we really look at how we're initially responding to things, and if we're examining what the long-term research is of neuroleptics is, and if we're examining how we're following up with people and what it is that we're actually doing here as human beings, how we're taking care of one another in community, then those are the important questions.
Right. Because as I understand, a big part of it is that because there's no prescription to treatment, that it's the discussion of treatment. It means that meds are an option, not a need, but vice versa. I mean, there's options for treatment. And I was discussing this with my friends in a group, and I was telling them, if I start a new medication, I may not know that it's having an adverse reaction, but you will. And I would need you to feel comfortable telling me that. And that if you're in my team and there's that safe space where you can say that, then you could make a difference in terms of that and how badly it affects me. Because if I'm on a drug for a long time that's having an adverse reaction, coming off of that drug is going to be even worse for me. And that kind of sprang up a whole conversation because several of us have been through that kind of situation. And some people would prefer to have the option of not having a medication, and some people, medication is a necessity. And finding out what other options are available, that's a conversation that I think might open up easier in that sort of a group, as opposed to just me and my therapist, because I don't know what questions to ask. Am I online?
Yeah, well, there's a lot of time and space given to deciding those kinds of things, and I think there's a real benefit to having a psychiatrist, who's educated around side effects and adverse events, and not only that, but interactions with other medical conditions, and they have a medical degree. So they are really important in the implementation, if you will. I mean, I don't mean to implement exactly what's in Western Lapland, but at least the training of what open dialogue is and how to put into practice what was working to decrease chronicity. You know, they're needed, and they have a wealth of experience in the room of family members and friends of somebody who knows them way better than they are. They know them, and also they're not the expert. I mean, the patient is, the client is, and they can have a real discussion if given the time and space in those network meetings. And medication is only part of in the toolbox of things that can happen. It's kind of become in psychiatric treatment a quick anesthetizing of symptoms, what we call symptoms. And if we really look at the history of the development of psychiatric medications, the point of them in the beginning is really to keep one from harming others or themselves and somehow decreasing difficult experiences. And so maybe we need to look at what we're really doing. You know, maybe we need to share difficult experiences. Maybe we need to use medications sometimes. In Western Lapland, they're not totally devoid of having compulsory, coercive medication situations completely. You know, even in their hospital, they do have that necessity at times, but it's greatly different than other areas in the world. It's part of the discussion, and it doesn't need to be the whole thing. And I don't think we need to divide and make an anti-psychiatry place to put blame of all the negative experiences. I think we need to invite what is the wealth of experience of psychiatrists, because they probably would be really happy to learn about a way to be with people that is shared among other professionals and have family therapists included and peers included, and remember why they went into the field to begin with.
Right. It's easy to kind of get lost in the job or the lingo.
Yeah.
That happens with peers as well. I know that as we have peers entering into the medical end of things, it's very easy to kind of get pulled into the field and forget what we came there for, forget our skills.
Yeah, it's important to question the hierarchies and also to trust our inner voices that are telling us what's important.
Mm-hmm. When I see a discussion about medication and whether or not forced medication should be a thing, and behavior being the token, and this is something that actually came up today in my own life, and examples being given about this behavior and that behavior, then is it okay to have forced medication? And on my own personal end, and this again is my personal feelings, those behaviors are telling me something's going on. Those are their own story. And if I medicate that away, it's tearing pages out of a book. And that to me is a very dangerous and scary thing. But there are people who don't want to read the whole story. As long as it's not being torn out of somebody else's book, that's the thing that's scary to me. And I like that for this particular system, I know in the past that there's been powwows done and that the person who is being treated, their chair is empty. And this is something where that never happens. That they're present and that they get a say and that they get to hear the discussions that are happening. That they're aware that nobody's ever making those decisions for them. And that is what really warms my heart the most, because I remember being that teenager who was informed as to what was going to happen, only to find out years later that it was a misdiagnosis, and all of those decisions were actually making the situation much worse. So I'm I'm really excited that this is something that's going to be more and more introduced. And I'm really hoping that each of these seeds continues to go out and drop more seeds.
Yeah, me too. The powwows should be taking place in the same teepee that the person who's having the concern is in.
Yeah, I agree with that. So is there anything else you think that you want to share?
Well, I can always share more, but I am, happy with the way we just talked about what I'm very, very passionate about, and I am trusting that the people that will show up to the training will be the right ones, and those seeds are going to go to the right places, and we just don't know. It's all one of the principles in open dialogue is the tolerance of uncertainty, and that's something that in the present moment and all present moments is very challenging for us to do, but that's where I am choosing to operate from.
I like that. I feel that way. I'm hoping right there with you.
Thank you.
Positive energy flowing that direction. Yeah.
Yeah. And it's really important work you're doing, this podcast, and just having discussions about, where to go from here.
I appreciate that. So,
thank you.
Yeah, thank you. And do you have anything you want to plug, any shout outs you want to give? I'm going to put your Open Dialogue Washington link in the description, and anything else you want, you can give me and I'll put in there, but I can give you...
I'll thank Open Dialogue UK for helping me get this started in Washington, Nick Putman, and John Harold for introducing me to Rethinking Psychiatry, and to you and Hearing Voices Network, and also all of the clinicians who in the late 1970s and early 1980s in Western Lapland listened to their own intuitions and trained themselves really well. Brigitte Alcara, Jukka Alterman, and Jaakko Sekula, who were really tireless in their not knowing what to do and in just examining what worked. And they continue to be that way. Even though they're retired, they're still continuing training what they learned. And I guess the last shout out would be to all the people that have had experiences, lived experiences that are really important to share with people, because I've heard it said, sitting with people, that that's one of the most important things for them to have in a network meeting, is to have people who have had experience having difficult times and are older and can share what they've gone through.
Thank you so much.
You're welcome.
And thank you for listening to the Three Voices podcast. We would love for you to be a part of the conversation. So if you have any questions or comments, please reach out to us at our Facebook page, Instagram, Twitter, or through Gmail. Until next time, don't forget to take care of yourself and each other.